Today with me here is Dr. Afzal Waghat. Dr. Waghat, good afternoon.
Good afternoon, Annel.
And so in today's discussion, Dr. Waghat will be telling us about long COVID and sleep. Quite an interesting subject. Usually when people talk about long COVID, loss of sense of smell, other neurological defects, but then when it comes to sleep, it's something which is quite unusual. And sleep is something which is very important, and Dr. Waghat will be establishing the relationship between the two and delving more into what we can do. So just to give you a brief background about Dr. Waghat, he's currently based here at the University Teaching Hospital. He's a registrar in his final year of infectious disease training, but he does have a master's in internal medicine from the University of Zambia. Joining us today is a panel of experts. We're going to just quickly run through their names. We have Dr. Kondwelani Mateyo, a pulmonologist consultant. We have Dr. Chomba Mashina, a neurologist. We have Dr. Chalomba Chitanika, a physician. Dr. Kelvin Simpamba, a cardiologist, and Dr. Naeem, Dalal, a psychiatrist. Quite a very rich field that we have here with us. And so without spending much time on the preliminaries, I think I'll hand over to Dr. Waghat to quickly run us through the presentation in the next 30 minutes. Dr. Waghat, over to you.
All right, thank you, Annel, and good afternoon, everyone. So today's presentation is about long COVID-19 and sleep. So our objectives for today are to outline sleep symptoms in long COVID and just in general also with sleep disorders, to describe sleep disorders and physiology in long COVID, to describe the possible etiologies of sleep disorders in long COVID, and to outline treatment strategies that we can use for sleep disorders and especially in long COVID. So the first question is, of course, what is sleep and why is that important? I think we all know what sleep is, but in terms of definition, it would be difficult to define it. But we can define it as a reversible neurobiological state, which is characterized by different activities in terms of brain activity, and there's dissociation from external environment. And during this time, when we sleep, it's characterized by reduced motor activity and metabolism. And during sleep, there's different physiological mechanisms that have been activated and are ongoing to allow the body to rest. And sleep is an important physiological need, and we cannot survive without it. And why is it important is that there are more than 80 sleep disorders described, and most of which are treatable. And then deprivation of sleep can lead to several things. It can lead to emotional instability. It can affect cognitive functions. So your memory can be impaired, and even your daily tasks are impaired, and to such an extent that you can actually be a hazard to your fellow colleagues or people you are working with. And it can also threaten your livelihood, as if you are clumsy at work, then you are putting your fellow workers at risk. And also, it's also associated with increased risk of communicable diseases. So sleep disorders are associated with increased risk of stroke, cardiovascular diseases, and also metabolic dysfunction. And sleep disorders are also associated with increased mortality by 1.5 to 2 times. So sleep is quite important, and to identify sleep disorders is also important. And one of the challenges is that in our training, we hardly focus on sleep, so it might be something difficult to think about as a problem. So in terms of biology of sleep is basically governed by a synergistic process of the circadian rhythm and a homeostatic drive. So these two processes are working together to govern our sleep. And so we can start with a circadian rhythm. So almost all living things have a circadian rhythm. Think of it as an internal clock that governs our physiology of the body. And in humans, our circadian rhythm is about 24 hours, slightly longer than 24 hours. And the circadian rhythm is governed by some genes that are just above the suprachiasmatic nucleus, referred to as the clock genes. And these genes are tied to the secretion of melatonin from the pineal gland. And melatonin is something that signals our body to go to sleep. So as melatonin increases, then you have this sensation of wanting to sleep, and you would want to sleep. And the circadian rhythm is influenced by external factors, and the most important external factor is light. But there could be other factors such as work that could also influence the circadian rhythm. Now, the other part is a homeostatic drive. This is an innate drive. With every passing hour, you feel this urge. Every passing hour that you're awake, you feel this urge of falling asleep. And this is like an innate drive of wanting to sleep. So both the homeostatic drive and the circadian rhythm should be in synchronicity. So every hour that you're awake, there's this innate drive of you wanting to fall asleep. At the same time, as the day is progressing, the melatonin secretion is increasing as the light fades, and the homeostatic drive at its highest when you're feeling sleepy. And in terms of your circadian rhythm, melatonin at its peak, you should have this sensation of falling asleep. Now, if there's dysynchronicity in this, the circadian drive and the homeostatic drive are not synchronous, then it confuses your internal clock and the sleep mechanism, and you'll have sleeping difficulty. And the classic example is jet lag, where if you've covered different time zones, then this thing can become dysynchronous. You're awake and you're feeling sleepy, but it's light outside, and so you can have dysynchronous activity. Now, in terms of sleep, sleep is not homogeneous when you go to sleep. So once this has happened and you fall asleep, sleep has different stages. So there's what you call generally rapid eye movement sleep, and then there's non-rapid eye movement sleep, so referred to as REM and non-REM. So REM makes up about 20 to 25% of your sleep, and then the non-REM makes up the remaining 75% of your sleep. But this is broken down into N1, which is light sleep. If you call someone during this sleep, they're likely to wake up. N2 is also light sleep, but a bit deeper than N1. And if you call someone during this sleep, they will not wake up. And then N3 is deep sleep. So during non-REM sleep, the cognitive function is reduced. During REM sleep, cognitive activities of the brain are increased, and this is the stage where you dream. Now, this N1 is usually lasting 10 minutes, and this whole cycle lasts about 80 to 120 minutes, but we sleep for longer than 120 minutes, so this cycle keeps repeating throughout the night. And as we go, as the cycle repeats more, then the REM also increases, and so you're more likely to have vivid dreams or dreaming during later part of the night. So this is basically the biology of sleep. And if any of this is affected, then you can have sleep disorders. So in order to sleep, we need to think about components of healthy sleep. So what is important in sleep is that sleep has to be of sufficient duration. And this is dependent on age. So as an adult, you need about 6 to 9 hours of sleep. If you've noticed in infants, they sleep about 16 hours. And as they grow further, then the sleep amount reduces. Sleep has to be continuous. It should not be fragmented. And some sleep disorders, such as obstructive sleep apnea, patients might not even recognize that the sleep is not continuous. Sleep has to be efficient, so the amount of time that you're spending awake in bed should be reduced. So you hit the bed and you fall asleep almost immediately. So that's also an important component, and it should be appropriately timed. So you want to sleep when it's time to sleep. So for example, at night. And there could be factors that don't allow you to do this. And then finally, sleep has to be restorative. So if you fall asleep, when you wake up, you have to feel refreshed. Yeah. So when we're thinking of sleep disorders, we can group them into different categories. So we can think of them as insomnia, where someone is having difficulty falling asleep. We can think of sleep-related breathing disorders. And in this one, the classic example is obstructive sleep apnea. We have central disorders of hypersomnolence. Here we have narcolepsy and catalepsy, where somebody has this sensation of or has excessive sleepiness and may be associated with hallucinations, lack of muscle tone, and it's frequently mistaken for seizures. So this is a disorder. We have circadian rhythm sleep-wake disorders. This one classic example is with shift workers, people who work night jobs, for example, or have alternating timetables of day shifts and night shifts will suffer from this one because the circadian rhythm is out of sync with their work patterns. We have sleep-related movement disorders. Here we have movement of the leg or bruxism, where somebody clenches the teeth at night. Parasomnias, we have nightmares, vivid nightmares here in sleep disorders. So these are things, when a patient comes to you, you can categorize according to this. Now, in terms of features of sleep disorders have a very wide range of presentations depending on these categories. But generally speaking, patients might come with difficulty falling asleep or maintaining sleep. They might have early awakening. They have excessive daytime sleepiness or fatigue. This presentation is quite common, and it can be to such an extent that the patient does not even realize that they're having sleep disturbances. But on further questioning, it becomes obvious that perhaps that is one of the cause. So this, if you have a patient with fatigue, then you must think of a possibility of sleep disorders, snoring loudly, abnormal behaviors of movements during sleep, and clumsiness as well. You could also have breathing difficulties, cough. So the breadth is quite wide. But if you have somebody presenting with fatigue, then you must start thinking of sleep disorders as a general rule of thumb. So in terms of symptoms of long COVID, if we have a look at long COVID, we have many symptoms and many systems that are affected. But if you check top of the list, then we have neurological ailments, we have fatigue, we have sleep disturbances, we have cough, wheezing, which can also present in sleep disturbances or such as obstructive sleep apnea. But if you check fatigue is a feature of sleeping disturbances, but it can be a feature of other conditions as well. Sleeping disturbances, this fatigue could be explained by sleep disturbances in a large part. And if you check in terms of incidence, so the incidence ranges depending on the studies that you're looking at, and it can range from 5% to as high as 80%. And over here, we're just crossing the 50% mark, between 50 and 60%. So in our long COVID clinic, we should be seeing quite a few patients with sleeping disturbances. And if we're not, then perhaps we're missing patients with possible sleep disturbances. It's quite a common feature of long COVID. And generally speaking, in terms of mechanisms of long COVID, there are several. Firstly, many systems or almost all systems can be affected in long COVID, and we have the CNS, the pulmonology, cardiovascular, GI, immune system, neurological system affected by long COVID. And there are several explanations for this in terms of it could be gut biome dysregulation, it could be neuroinflammatory causes, it could be cardiovascular or reduced blood flow causes as a general rule of thumb, or as general causes. But these things are being investigated. There are areas of active research. In terms of neurological system, because sleep, usually it's neurological or pulmonological or psychiatric in nature. In terms of neurological system, cognitive impairment and sleep fatigue and disordered sleep would fall under here. And the thoughts are that it could be dysautonomia, it could be neuroinflammation, could be reduced blood flow, and which is basically falling under these mechanisms. High on the list is neuroinflammation as a cause, and but it's still area of active research. Now, interestingly, for long COVID, there's studies being done where they're looking at MRIs of the brain and brainstem, and they're trying to look at different areas of life or functioning and trying to relate them to these changes that they're seeing in long COVID. So in this study, they had a cohort of patients with MRIs before COVID and compared it to patients after COVID. And they were looking at two things. In this table, they were looking at brain volume in different brain areas. And in this picture, they were looking at functional MRI, so basically the functioning of the brain at 32 different locations and its relation to different sleep areas. So what was found is patients who had brain loss in these areas had increased association with sleep disorders. So here we're looking at the sleep disorders and brain loss, and they were looking at several things. They were looking at anxiety, depression. They were looking at excessive daytime sleepiness, using different scores and tools to look at that. So that was quite interesting that they found physical evidence of brain volume loss in patients with long COVID and a strong association with sleep disorders. And this takes us to our next point very nicely, is that if you see here, they're doing different questionnaires. And in sleep disorders, generally, there's a myriad of sleep questionnaires that can be used to diagnose different types of sleep disorders. I've highlighted two famous ones. The first one is the Epworth Sleepiness Scale, and then the Pittsburgh Quality Sleep Index. But honestly, almost every sleep disorder, if you were to try and search for a sleep score, you would find something. But these two are just basically like umbrella questionnaires that you can use to screen for sleep disorders. The first, we'll talk about Pittsburgh Quality Sleep Index. This one is so the questionnaire can be found online. It's quite long and a bit comprehensive, but it's self-reported, and the patient reports on sleep quality, latency, duration, sleep efficiency, disturbances, medication, and daytime dysfunction. And it's self-reported. And if there's a score greater than 5, then it's considered to have a disturbance.
Kindly mute our mics.
Yes. But one of the limitations of this is that it's self-reported, and most sleep scores are self-reported, so that's a limitation of many sleep scores. The next one is Epworth Sleepiness Scale, and this one it informs us about the daytime sleepiness of a person, and they're given points 1 to 8 is normal sleep, 7 to 8 is average, and then 9 to 24 is abnormal sleep, and basically gives us an idea of excessive daytime sleepiness. There's two issues with this score. Firstly, it's subjective, and that what can be slight chance of sleeping for me might be moderate chance of sleeping for someone else. So that's a limitation. And the other limitation in practice from my experience has been that to use it in our population is a little bit tricky, because there's things in here like, for example, watching television or sitting and reading, and many of my patients would not read, so it would be difficult to score, or something about transport, like sitting in a car, in traffic a few minutes. And so this is a little bit tricky to apply in our setup, but nonetheless, it's an important score to be aware of. So now we will discuss the etiologies of sleep disturbance. So we saw that sleep disturbances or sleep disorders was ranging from 50 to 60% at least in terms of sleep disorders in long COVID. But sleep disorders, usually when looking at research, they lump them together as sleep disorders. So it's difficult to delineate between the different types of sleep disorders. But generally, insomnia, obstructive sleep apnea, and restless leg syndrome were quite common in terms of long COVID and sleep disturbances. Insomnia there was an incidence of about 20 to 40%. OSA ranged from 15 to 60%. Restless leg syndrome ranged about 15 to 30% in terms of prevalence of sleep disturbances in long COVID. I just did a quick analysis to look at how many of my patients in the obstructive sleep apnea clinic had COVID previously. And you can see it's almost 50% of my patients in obstructive sleep apnea had COVID. I'm not saying that they had OSA because of long COVID, but it's an interesting statistics. And if there can be 50% of my patients presenting, about 50% of my patients with OSA had COVID previously, then there's a possibility that many of these could be because of COVID. So we will move into the first scenario before we start discussing a few of these topics. So, one question.
Yes, so the scenario is a male 34 years presents to the clinic with complaints of having difficulty falling asleep for 6 months. He has no obvious stresses on history. He spends time on the phone before getting into bed. He usually gets out of bed and paces about and watches television. A diagnosis of insomnia is met. So we go into the first question. What is the next best step to his treatment? IT, if you can help us to load the poll question. A, prescribe a benzodiazepine in the evening. B, cognitive behavioral therapy. C, prescribe melatonin agonists. So the poll has been loaded. You can go to the poll section and quickly give us feedback. Then we can get into it. So I'll run through the scenario as people are polling again. 34-year-old male presents to the clinic with complaints of having difficulty falling asleep for 6 months. He has no obvious stressors on history. He spends time on the phone before getting into bed. He usually gets out of bed and paces about and watches television. A diagnosis of insomnia is made. So let's continue to poll on what is the next best step to his treatment. Either A, to prescribe a benzodiazepine in the evening, or B, cognitive behavioral therapy, or C, prescribe melatonin agonist to him. So we've seen 9 have polled. We'll just give it 30 seconds. 52% of our participants have polled. We can increase that more. Give it a few more seconds before we go to the next part of the presentation. But very interesting discussion, Dr. Waghat. You've touched on quite a number of things on what is the definition of sleep. Usually most people just talk, oh, I'm going to sleep, but what is the textbook definition of it? And then it's good to learn that there are more than 80 sleep disorders. Most people, when talk about sleep disorders, just think, oh, I can't sleep, I have insomnia, and that'll be it. But we've learned today that there are more than 80 sleep disorders, and the association between sleep and mortality, the fact that poor quality sleep will increase your mortality by risk factor 1.2 is actually very interesting to know. And so with that shared, I think we'll get into the next part. We've had 52% have participated in our poll. And so with 78% thinking this client deserves cognitive behavioral therapy, and 22% saying you need to prescribe a benzodiazepine in the evening. No one has talked about prescribing melatonin agonists. So there we go. And so those are the results. And so we'll move into the next segment of our presentation. Okay.
All right. So what is insomnia? So insomnia is basically someone having difficulty falling asleep or maintaining the sleep. They might fall asleep, but then wake up and then have a failure to fall asleep. And this might result in daytime sleepiness, irritability, or fatigue, but it's not necessary. So only about 10% of people with insomnia will have daytime sleepiness or fatigue. And mostly the causes of insomnia remain unknown, but there could be several contributing factors. There could be psychological, or it could be some social pressures, behavioral, maybe they're on the television, or or it could as well just be neurological causing the insomnia. So they might be contributing factors. Remember when we looked at the components of healthy sleep, if any of those might be affected, then you could have insomnia. Now with insomnia, generally speaking, patients usually present with that complaint anyways, that I am having difficulty falling asleep. So the diagnosis is mainly clinical. It's the patient will come to you with that complaint that I am having difficulty falling asleep. And this could be less than 3 months, in which case it can be considered acute, or it can be greater than 3 months, in which case it's considered chronic. So the diagnosis is mainly clinical, but to help us make the diagnosis in maybe gray cases or where it's a little bit difficult, we could ask the patient to do a sleep diary where they, over a course of a month or 2 weeks, note everything to do with their sleep, the time they get in bed, the time they fall asleep, if they wake up in the middle of the night, when they wake up, how long do they wake up, what time do they wake up, is the sleep, do they feel refreshed? So they could do a sleep diary. And this is just not with insomnia, but you could use a sleep diary for all sleep disturbances. You could use insomnia severity index. Like I said, with sleep disturbances, you have many tools that you could use. And you could also do actigraphy, which is shown here. Basically, it's a device that is engineered in a way that it's unobtrusive. So you wear it on the hand or the leg, and it monitors leg movements or muscle movements. Because one of the causes of insomnia could be muscle movements or limb movement, for example. But this is not really necessary. The diagnosis is usually clinical. In terms of management, I think many of the people hit it on the nail, that management is cognitive behavioral therapy. And we use what is called sleep hygiene to basically encourage the person to sleep. So cognitive behavioral therapy is more long-lasting as compared to pharmacological therapy in terms of insomnia. So basically, we could ask the person to restrict sleep, the amount of time they spend on the bed. So if they're napping during the day, we encourage them to not nap during the day, or to nap, maybe instead of napping 90 minutes or 80 minutes, take a 10 or 20-minute nap, and only go to bed when they feel that urge to sleep. If they get in bed, not to get up and start pacing about. Then stimulus control therapy. So before going to sleep, maybe somebody's on the phone or watching television. So to stop watching that, light can affect our sleep as well. Many phones now have blue light filters, which we can also put relaxation therapies, and then also identify behaviors that may be contributing to us. For example, if they're taking coffee in the evening, discourage them from doing this. If they're smoking in the evening, discourage them from doing this. Also identify things that might be causing anxiety and how to deal with this. For example, they could do exercise in the morning to try and deal with the stress that they might be having. So these are some of the things that we could do in terms of encouraging someone to overcome the insomnia. In terms of pharmacological management, the list of drugs is quite large. It can be benzodiazepines, you can have melatonin, you can have over-the-counter drugs like the antiemetics that have the side effects of causing sleep, tricyclic antidepressants. But in general, we try to do cognitive behavioral therapy. There's also restless leg syndrome, which is something that is observed in patients with long COVID. And this one is characterized by the urge to move legs. And usually we have an unpleasant sensation in the legs, like a creepy, crawly type of sensation. And usually happens when they are resting or in the evening or when they're inactive. And the sensation is relieved with movement. So this might affect their sleep. And it could also be one of the causes of insomnia. For this, again, diagnosis is clinical, but there is an association between iron deficiency and restless leg syndrome. So it would be good to do an iron study to check for iron deficiency. In terms of the next one, this one's a big one, obstructive sleep apnea. So if you look at the statistics, just without COVID itself, it's quite huge. 1 billion people are affected, and the current population is about 8 billion. So that means 1 in 8 people are affected with obstructive sleep apnea, which is quite high. And in terms of affecting the economy, it costs about 150 billion in lost revenue because of the effects it has on people and their productivity. And so it leads us to what is sleep apnea. And when we talk of sleep apnea, we think of it just in terms of sleep. Yes, of course, it's the pathology is that there's these apneic spells that are happening during sleep because of narrowing or closure of the airway during sleep. But then this leads to a cascade of things downhill. It leads to obesity, but obesity also leads to sleep apnea, which is a vicious cycle to try and break out of. It causes pro-inflammatory condition. It's a pro-inflammatory condition. It causes further down metabolic dysfunction, type 2 diabetes. It can cause erectile dysfunction. It can cause stroke. It can cause blood pressure that is difficult to manage. So it's really a patient can present with any of these, not necessarily come to you, oh, I'm having difficulty falling asleep. It's one of those things that is difficult to pick up on. So it's important to have a high index of suspicion. And you can see the downstream effects are quite large. So this is something that is a huge problem, but it's unrecognized. Only 1% of people with obstructive sleep apnea have gotten a diagnosis of sleep apnea. So out of 1 billion people, only 1% have had the diagnosis of sleep apnea. And now we have long COVID also driving this as well.
All right, quite an interesting discussion here in the presentation of Dr. Waghat. And so we get into scenario 2. A patient presents to you with increased clumsiness at work while operating heavy machinery. His employers are worried about safety whilst he's operating heavy equipment. He agrees to feeling fatigued during the daytime, but is unsure why. He feels he sleeps well. You suspect obstructive sleep apnea has a cause. We get into poll question 2. IT, if you can load the poll for us. So what sleep questionnaire will be best applied here? So we have different sleep questionnaires. There's the Stop Bank score, the Pittsburgh Sleep Quality Index, Epworth Sleepiness score. No score has clinical history, and exam is sufficient. So let's get a polling as I run us back through the scenario. A patient presents to you with increased clumsiness at work whilst operating heavy machinery. His employers are worried about safety while he's operating heavy equipment. He agrees to feeling fatigued during the daytime, but is unsure why. He feels he sleeps well. You suspect obstructive sleep apnea has a cause. Thank you. We've seen about 20% of the network has polled. Let's continue to poll, and then we'll give it a few more seconds and we get moving. So what sleep questionnaire will be best applied here? Is it the Stop Bank score? Is it the Pittsburgh Sleep Quality Index? Is it the Epworth Sleepiness score? Or is it no score has clinical history and exam is sufficient? We'll give it a few more seconds. 47% of the network has polled, which is slightly less than in the first poll. We can have a few more people polling, and then we can move on into the next segment of the presentation. But it's quite interesting to note about sleep apnea in the slide where you showed us to say it can result from obesity, or obesity can result from sleep apnea. And so you see that it's kind of like a vicious cycle. Yes. So one can lead to the other, or the other can lead to the other. And then we have a whole host of other symptoms and syndromes coming in from that. So I think we'll end the poll here. We have, just get that, we'll end the poll here. And then we see that 33% are saying the Pittsburgh Sleep Quality Index, 33% are saying the Epworth Sleepiness score, and then 33% are also saying no score as clinical history and exam is sufficient, and nobody has talked about the Stop Bank score. So Dr. Waghat, people have evenly distributed amongst the B, C, and D options. So let's get into the next part of the presentation. Dr. Waghat.
All right, thank you, Dr. Sinkala. I just wanted to clarify that not all sleep apnea patients will be obese, but there could be other factors as well, such as trauma to the mouth, or which might cause an abnormal anatomy of the upper airway that could also cause sleep apnea. So it's not always obesity, but about at least 60% of sleep apnea patients, obesity is the cause. Yes. So in terms of the question, we saw everyone, there was an even distribution between the answers. And again, I want to highlight for almost every, like basically sleep disorders, there's scores that you can apply. And in terms of obstructive sleep apnea, of course, you can do the Epworth sleepiness score or the Pittsburgh score to determine if there's an overarching sleep disorder. But in terms of OSA particularly, the Stop Bank score is the one that is used. And this is quite a sensitive tool. And we're looking at two components, Stop and then Bank, so the Stop Bank score. So, and what I like about this score is there's no in between. It's not subjective. It's a yes or no, yes or no. And depending on the score, you can have high risk if the score is 5 to 8, intermediate if it's 3 to 4, and low risk of obstructive sleep apnea if it's 0 to 2. And in this, we have some of the risk factors associated with obstructive sleep apnea. So the first question is, do you snore loudly? And people who have obstructive sleep apnea tend to snore. Do they feel tired, fatigued, or sleepy during the day, which does tend to happen? And usually the patient does not even recognize that their sleep is affected. And then this is a question for somebody who sleeps with a patient or somebody who has observed the patient. Have they observed the patient stop breathing during sleep? And maybe if somebody presented to you with this, then you might think of heart failure or something along these lines, but it could be sleep apnea. And are they being treated for high blood pressure is another risk factor. And then the other risk factors are, do they have, are they obese? Basically, is the BMI greater than 35? Are they greater than 50 years of age? Another big one is the neck circumference. If it's greater than 40 centimeters or 17 inches, then there's an association with sleep apnea. Basically, the large neck would compress on the upper airway structures. And then gender being male. And then you score this and it will give you a risk of obstructive sleep apnea. And you can see that as the score increases, then there's an increase in the association with obstructive sleep apnea. But of course, this is not diagnostic, but it gives you a high index of suspicion. And in terms of our patients here at UTH, at the sleep apnea clinic, none of the patients who had a stop band score less than 3 had sleep apnea, but everyone above 4 had at least an element of sleep apnea, and they mostly clustered around a score of 6 and 7. So this was an interesting statistic. In terms of diagnosis, there are several studies that can be done. So there's polysomnography. This is the gold standard in terms of diagnosing sleep disorders. And it involves EEGs to observe brain waves. It also includes EMGs, basically to monitor muscle movement, saturations to monitor for saturations, snore sensors. And this is done at a sleep center, so the patient has to come in hospital. And it can be diagnostic. So you spend half the night sleeping with this and getting diagnosed, and then half the night trying to, if it's sleep apnea, titrate your machine while on polysomnography. But in today's time, things have moved on to home sleep studies, and we have now devices that you can go home and sleep with, and it will give you these parameters here. And in terms of sensitivity, it's almost equal to polysomnography in diagnosis of obstructive sleep apnea, that is. Just an important point, polysomnography can be used for many sleep disorders, including obstructive sleep apnea. But currently, in terms of these home sleep devices, it's targeted towards obstructive sleep apnea. However, it has revolutionized the practice of obstructive sleep apnea. And here, I just wanted to highlight, this is for one of our patients here with obstructive sleep apnea. And when you're diagnosing obstructive sleep apnea, you're looking at something called the apnea-hypopnea index. So basically, because of the obstruction, a patient will go into apnea. So they'll have this apneic spell, and we're looking at the number of apneic spells they're having and dividing it by the number of hours to get a value. So any value greater than 5 is considered obstructive sleep apnea. And this patient had a value of 87.5. And so this keeps on happening throughout the night. They'll have an apneic episode, they'll come out of sleep or just go into light sleep, and then it repeats. So they'll go into light sleep just enough to stimulate the muscles so they opens the upper airway. And interestingly, for this patient, you can look at the desaturations. This patient spent 4.5 minutes fragmented, not 4.5 in a go, but maybe 20 seconds, 40 seconds, at saturations less than 70%. And on average, this patient's saturations were 90%. And this is happening throughout the night, every night. And so it really affects the patient during the daytime. So in terms of management, main modality of management is CPAP, continuous positive airway pressure. And the newer machines are even self-titrating. You buy them, you put them on, and the machine will titrate itself according to your sleep and how. So it's basically buy off shelf, and you can use it almost immediately with the newer machines. So CPAP is the therapy of choice. However, there are other options as well, and the first one is weight loss and lifestyle modification. But the challenge with this is you saw the vicious cycle. Obesity will lead to sleep apnea will lead to obesity, And this is a very difficult thing to break out of. And so generally, we go to CPAP machines. But with my patients, I have seen patients put in an incredible effort to actually lose weight and reverse the sleep apnea. So it is possible. The other option are oral devices, which basically open up the upper airway. But this one, it's not as good as CPAP machines. They're not as successful as CPAP machines. However, it's an option to consider. So number one management is CPAP machines. All right. Thank you, everyone.
All right. Great presentation, Dr. Waghat. Very interesting topic, long COVID-19 and sleep. So at this point, what we'll do in the interest of time, I'll ask the panel of experts that we have to come in and add on to what Dr. Waghat has taught us. And then to the network, if you have any questions, you can raise your hand or you can simply unmute yourself and ask your questions. So looking through the chat to note if there are any questions or even any additions to the topic. Maybe anyone can unmute and share their experience with us on sleep. Dr. Chomba Mashina, do you have any additions to Dr. Waghat's presentation or any just one or two liners from your practice? You can go ahead.
Hello, can you hear me now?
Yes, we can hear you now.
Thank you. I was not muted. I was not unmuted for a while, so I couldn't say anything. But Dr. Waghat's presentation was very good, very excellent. And that was a very good summary of sleep disorders and the sleep physiology. I don't have much to add because it was very thorough. The only thing I would state is the way we think of sleep disorders would be exactly as Dr. Waghat mentioned. But I also like to talk about and also like to caution that needs or sleep needs differ from person to person. So what works in one person might not exactly work in another. And the point of sleep is that at the end of it, you've achieved effective rest for the brain to recalibrate. And so the approaches must be tailored towards that. And even the diagnosis, you have to be a bit careful. As Dr. Waghat was mentioning, when you diagnose insomnia, for instance, be very careful. What's insomnia in one might not be insomnia in another. The sleep needs differ. And so you have to be very, very careful. Regarding long COVID and sleep, a very interesting subject and lots and lots of research that's still going on to properly understand the full physiology. Questions that we have right now, is it inflammatory processes? Is it processes to do with actual cellular death in the brain that is leading to this? Is it extraneural? Is it a hormonal problem? Is it signal pathways that are interfered? So there's a lot of questions there, but definitely a good summary of how we think about sleep disorders in relation to long COVID. So thank you very much for that excellent talk, Dr. Waghat.
Thank you, Dr. Chomba, for your input, and we appreciate your expertise. And I think one key point that you have mentioned is that we need to tailor the diagnosis to each individual. And like Dr. Waghat had emphasized, some people sleep for 6 hours, others will sleep for 9 hours, and depending on the individual, 6 may be enough for one, it may not be for the other. So very important to tailor each one. And if there's anyone on the network who has any contribution or any questions for Dr. Waghat or for our panel of experts, please feel free to unmute yourself and make a contribution. And as we were waiting for people, maybe I could ask Dr. Waghat one or two questions. It was quite interesting on your stop bank score. I noticed that there was male, so I started looking. Male is already a risk. There's already one there. So am I already at risk being a male? but then quite reassuring when we hear that, no, it has to be taken into context. And so most of the time we see people would complain to say, well, I'm having difficulties sleeping. Meanwhile, they've been working night shifts. So I think then they would go over the counter and then they would get Piriton. Is that a practice that you would encourage? Or what would be your comment on that in the advent of long COVID-19 and sleep disturbance? The use of over-the-counter Piriton as a sleeping pill, or maybe they should lean on to cognitive behavioral therapy. A quick comment, Dr. Waghat.
So for that, I would not advise just going over the counter Piriton or anything like that. So it does affect shift workers. So they have to find ways around this. So for example, if basically the cycle is a little bit offset, it's desynchronous in them, but there's ways to trick the brain into thinking that day shift and night shift. So you could use light therapy, for example. You could use blackout curtains. You could use earplugs to basically enhance the environment, like during daytime, in terms of trying to get sleep. And then so it is basically cognitive behavioral therapy in a way. It's sleep hygiene, and if additionally in terms of therapy, melatonin has been shown to be effective in these patients. But ideally, first you want to try sleep hygiene techniques.
All right, great. And then I think the last point, and then you can give us your just 2 or 3 line summary. We noted that in the long COVID symptoms that were shown us there, sleep disturbance was at number 3, quite high. But then in terms of the numbers that we're seeing in the clinics, they are quite low. And then I noted the relation when you mentioned about sleep disturbance as being at number 3, and then fatigue was at number 2. Could there be a correlation with the two in terms of are people coming in fatigued because they're not getting quality sleep? Or are people, what is the correlation? What is your comment on that list?
So, yeah, thank you. So in terms of...
Maybe before we get to Dr. Chomba, you can go ahead. I've seen your hand is up, and then Dr. Waghat can come in and go ahead, Dr. Chomba.
Thank you. Just wanted to absolutely state Piriton is not used for sleep. I just want that to be extremely clear. No one should ever take Piriton to sleep. And that is just a big, don't do that. And stick to what Dr. Waghat has described. Sleep hygiene is the most important. Thank you.
Thank you for making that very loud and clear. I think it's supposed to be encapsulated. Do not take Piriton for sleep because you're failing to sleep. Dr. Waghat, back to you.
Yes, so in terms of causes of fatigue, there are several causes of fatigue. It doesn't necessarily have to be sleep disturbances, even autoimmune conditions. So long COVID, and there's this features of basically muscle pain, joint pains. It can affect the pulmonology system, the cardiovascular system. All of these can cause fatigue. So that's interesting because in terms of, because they're looking at different studies, if you notice, sometimes they've put in lumped diseases together and sometimes they've mentioned symptoms. So it's a little bit tricky to analyze, but fatigue can be caused by many things. But in terms of sleep disorders, fatigue is a prominent feature as well. I hope that clarifies.
Very much clear. You can just summarize for us, Dr. Waghat, and your last comment in the last 1 or 2 minutes as we close.
All right, thank you. So sleep disturbances in general are quite common and they're quite underdiagnosed. Maybe it's because we usually don't think about them, but they're quite common. And in terms of long COVID as well, we've seen that at least about 50 to 60% of patients have sleep disturbances. So we should be thinking about them, especially in our long COVID clinics. If we're not seeing them, then we need to question why this is going on, not only in our long COVID clinics, but even general practice as well.
Thank you very much, Dr. Waghat. This has been an interesting discussion on long COVID-19 and sleep. I've been your moderator, Dr. Annel Sinkala, and with us we've had Dr. Chomba Mashina, who's been our expert, giving us expert input. Our presenter has been Dr. Afzal Waghat. And from the ECHO team, I would like to thank you all for joining us and wish you to have a blessed day. Thank you all. Until next time, have a good afternoon.